Hi, good afternoon now. My name is Jazmin Cole. Thank you for the introduction. And I just wanted to thank the moderators, Dr. Sheda and Dr. Yuza and SAGES for the opportunity to present today. I have nothing to disclose. Malignant bowel obstruction is a sequela of advanced intra-abdominal cancers, and it describes a bowel obstruction distal to the ligament of triceps due to severe tumor burden. In gastrointestinal and gynecologic cancers, the incidence of malignant bowel obstruction has been reported to be up to 28 to 40% respectively. Despite its rare nature, malignant bowel obstruction can still have a profound impact on patient quality of life. It can cause frequent abdominal pain, intractable nausea and vomiting, and then require several hospital admissions for management of those symptoms. Malignant bowel obstruction is also challenging for us to manage because there is no real defined treatment algorithms to help guide our decision-making. Management options currently for malignant bowel obstruction include surgical palliative bypass of the sites of obstruction, pharmacologic agents to treat symptoms, and then endoscopic decompressive gastrostomy tube placement. Standard gastrostomy tubes are pretty poorly designed for gastric decompression as they sit on the anterior gastric wall in a non-dependent location. So therefore, the dependent portions of the stomach are poorly evacuated. The Aspire-Assist gastrostomy tube by Aspire Bariatrics is an extended length gastrostomy tube. It features a 15.2 centimeter long, 30 French fenestrated gastric segment that sits in the dependent portions of the stomach, and it's different from the standard gastrostomy tubes that we're used to, which feature an internal bumper that sits opposed to the gastric wall. The Aspire Assist tube is FDA indicated for endoscopic weight loss. However, given the longer length gastric segment and potentially enhanced gastric decompression, we postulate that the Aspire Assist tube may provide benefit for patients suffering from malignant bowel obstructions. The goals of my presentation today are to review our group's experiences managing malignant bowel obstruction patients using the Aspire Assist gastrostomy tube, as well as to identify the safety profile of placing these tubes endoscopically in these patients. This is a retrospective study that was performed at a single institution where we reviewed all patients who underwent Aspire-Assist gastrostomy tube placement for malignant bowel obstruction by two surgeons between November of 2019 and July of 2021, or July of 2021, excuse me. The Aspire-Assist tubes were placed using a standard safe tract and Ponsky pool techniques. All the patients had preoperative imaging, cross-sectional imaging to confirm that there was a safe endoscopic window for gastric access. And those patients who were found to have a large volume of ascites on preoperative imaging underwent paracentesis prior to decompressive gastrostomy tube placement. We gathered pre- and post-Aspire placement data for comparison, focusing on the number of hospital admissions for malignant bowel obstruction symptoms and major complications like bleeding or the need for repeated upper endoscopy or return to the operating room. So as you can see from our patient demographics, we had a total of 14 patients that were identified and included in our study with an average age of 70 years old. The majority were women, and they all had a variety of cancer diagnoses with gynecologic cancers, including uterine, ovarian, cervical, and endometrial being the largest demographic. So the average number of admissions for malignant bowel obstruction during the 12 months leading up to decompressive gastrostomy tube placement was 1.6, with a range of 1 to 3. Following Aspire Assist placement, 12 of our patients had no further hospital admissions for malignant bowel obstruction. 2 had a total of 4 admissions for malignant bowel obstruction, and we had no major complications and no patients had to return to the operating room. Overall, the majority of our patients had fewer admissions for malignant bowel obstruction following placement of the Aspire Assist gastrostomy tube. And so this suggests that the longer gastric segment of the Aspire tube may provide enhanced gastric decompression and therefore improve symptom management for patients with malignant bowel obstruction. By reducing hospital admissions following the tube placement, patients were able to spend more time at home and hopefully have an improved quality of life. Our findings also suggest that Aspire Assist tube placement is safe and is not associated with higher rates of major complications like bleeding, fistula formation, cardiac events, or venous thromboembolism. Our study is limited by its smaller volume given the rare occurrence of this disease, as well as our use of number of hospital admissions as a surrogate metric for patient quality of life. So in the future, studies may utilize a more detailed or nuanced patient-driven quality of life assessment that perhaps focuses on the ability to tolerate an oral diet to better understand the benefit of decompressive gastrostomy tube placement in these patients. There's also still work to be done to develop a reliable treatment algorithm for patients with malignant bowel obstruction, including optimal patient selection for the various interventions. Unfortunately, this future work will not incorporate the Aspire Assist tube specifically. Aspire Bariatrics recently announced that they will be halting operations and withdrawing the Aspire tube from the market as soon as next month. And so further innovation is necessary to develop a enhanced gastric decompression device that is specifically marketed for managing patients with malignant bowel obstruction, given the promising initial study findings. In conclusion, the Aspire Assist tube gastrostomy tube is safe for malignant bowel obstruction symptom palliation, and enhanced gastric decompression can reduce hospital admissions and improve patient quality of life. Thank you. I'll take any questions.